Good morning. Hi, everyone. My name is Ashraf Azzoni. I'm an interventional cardiologist in Cleveland Clinic. Thank you, Ronnie, my colleague from Cleveland Clinic, also my partner where we do such cases, and Dr. Ahmed Shatti from Kuwait. We'll present this case that we did just a few days ago. Is really about, actually, this is like a shifting gear where we will focus on how we prevent complications, how you do a left main bifurcation, trifurcation, PCI, probably with the highest success rate, and how you can reduce risk of complications and have a good long-term outcome. So maybe we can start the case now. Yes. So this was a 69-year-old male patient with limiting angina, past medical history of hypertension, dyslipidemia, type 2 diabetes, PCI to LED in 2013. Very strongly positive stress test at low workload with normal ejection fraction. This was the initial part of the PCI, so we didn't take many pictures, but as you can see at the ostium of the circ and the LED, there are like severe lesions causing significant stenosis. And the LED itself is stented all the way from beyond that narrowing to the very distal part. So there was no good like landing zone for a graft, so was turned down for surgery, and the patient himself completely declined the option of surgery. So we took him for a PCI. So we debated which technique to use. The one we are presenting here is the double rewire nano crush technique. So we'll go through the steps of this technique. But as you can see, the initial part we did here is after wiring both the LED and the circumflex coronary artery, we ballooned at the ostium of the circumflex coronary artery with a non-compliant balloon. Then we ballooned the LED into the old stents, as well as balloon the left main with a 3.75 non-compliant balloon. And then we started with our next step where we wanted to stent the circumflex coronary artery while having a balloon in the left main LED to crush it after we pulled the balloon. But maybe I'll just take a moment and ask my colleagues, Ronnie, like here in general, like here we chose the nano crush technique. Like what other technique would you choose? Is there any preference you have in general?
Yeah, well, so I think this is always a choice. You know, I mean, we have data to support, for example, DK crush against a culotte. I think when we're looking at these, the angle, the bifurcation angle becomes very important. Although this was, it's not, I wouldn't call it a true trifurcation as the label is, but you do see a high rising OM there. The advantage of the nano crush is, of course, less metal at that bifurcation point, and just have less likely risk of having more crush stent and ending up with a triple layer and a neocarina. The disadvantage is, of course, if you miss, then you might you end up obviously with a space and a gap in this particular case.
Yeah. So,
but we felt from the angles this would be favorable for a nano crush technique.
Yeah, so and we like the nano crush technique because literally we just only pull a small part of the stent into the left main, and the crushed part is actually a very small part. So you don't have a long area of 3 layers of stent on one side of the left main compared with the other one. Ahmed, I'll ask you, like, what techniques do you usually use in this case? Any specific thing that will turn you away from one technique versus the other?
We were trained at the same place, Ashraf, so we would go for a DK crush or nano crush here. But culotte is not a bad idea here as well, even though from literature, we know that nano crush and DK crush would be maybe a better results in the long term, comparing with the culotte. There is no size differences between the branch and the left main, so I think designs or would grow up to accommodate that left main a few with the branch. So I would agree with you. My only problem with the nano, which is also forgiving here, is if you miss the ostium, you might end up with an area of not covered with a stent, which is, again, this is maybe not a big issue here since the ostium itself is quite healthy. Maybe if you lift it, it's not a big deal.
And yeah, as you mentioned, and the role of imaging here really help where we can actually make sure we don't miss any part of the ostium. So here we did the initial part where we stented the circumflex coronary artery back to the ostium, and then we crushed with the balloon that we already kept in the left main into the LED, whatever we protruded back into the left main, and then we are going through the steps here one by one. But another question I have for you, Ahmed, hemodynamic support devices, do you use them routinely in such cases for left main? And if you do, like when do you use it and which one you use?
I don't use support devices for lift knee, simple lift knee. This is not a simple lift knee for sure, but I mean for a patient who have a good ejection fraction, and he's fine, he's been doing well. It's not a crashing patient, so I wouldn't. And my first choice for support still is a regular intra-aortic balloon pump. And then if the patient would require more, I would upgrade to a, but I start always simple with those cases.
And I would add, he didn't, if your RCA, I mean, I guess you would, this is a patient that's got a large RCA that's well perfusing, and you're not worried about, complete hemodynamic collapse if you're working on the left main. That also would help you in this particular case. But I think with a low EF, RCA is patent. You can favorably get away with not having to do support in such a case.
So this is actually like almost the full case done in less than half an hour. We did minor editing of the case. So at this point, we just rewired the side branch, which is the circumflex coronary artery. We find Pilot 50 wire is a good wire to do this kind of rewiring because it can, with hydrophilic coating, you can easily go into the side branch. And we use the double rewire technique because I think this is crucial. If you don't rewire and open the ostium of the circumflex coronary artery after you crush, and if you just go into stenting the left main into the LAD, then sometimes you get surprised by how many layers of stent you have from the left main into the circumflex coronary artery, where it becomes very hard to rewire. And even if you succeed, you cannot really actually push a balloon into the branch. So I think it's very important to do it step by step and not skip any step when you do this kind of technique. I'll go just one step back, Ronnie, for your question. Guides 6, 7, 8 French radial versus femoral in general when you think about a two-stent technique?
I think, I mean, at our institution, we've become very comfortable using radial as an upfront approach. I think a 7 French guide will be very helpful. It just makes things a lot easier when using larger balloons. This is a larger vessels, and you can get away with more, and there's less interaction of the equipment. So I would favor a 7 French guide, and if you can get it through the radio, I think it's very reasonable to do that. You spare the groins for access if you needed to get emergent hemodynamic support, particularly. And in this case, it's a distal left main, so I think you can use a supportive guide. There's no reason to be gentle with the JL. If you had more osteal disease, then maybe something like a JL would be a little bit more just safer.
Totally agree. Your 7 French would make your life easy and exchanging equipment way much faster if you need to go act very quickly. However, could be done with a 6 French. Like totally, could be done with a 6 French. But sheathless 7 French is way superior. Like if you are worried about that, the diameter of the radial artery, you could go sheathless 7 French and should be doable. And an extra support will make your life much easier than a jail.
So here we are reaching the step where we are stenting the left main into the LAD. So we sized it based on the angiography. But honestly, I'll show you the OCT at the end of the case. We did it post procedure here, but because he was elderly, some kidney issues and so on. But I think imaging is crucial in such cases, and in many cases, actually, the initial part at the beginning of the procedure is very helpful to help you plan it. For example, with OCT, you understand literally the morphology of the lesion, how calcified it is, do you need to do a atherectomy or no? And then also you can pick your size of stent based on the imaging you do. But in this case, because of the kidney function, we did not do it. But also we had the detailed report from his last PCI from 2013. So we knew what kind of distal vessel we are dealing with, what size of stent that is there, and based it on it. So we use a Zions SkyPoint stent 4O times 18, the left main into the LAD. So we took different views to make sure we can find cover most of the left main as we do it. We use Zions. This is the stent we use. So I think is a fair point to make is to actually know your stent, be familiar with it, especially when you use it in a more complex case. You don't want to use a stent that you are not used to, and it might be hard to crush or rewire after you crush and so on. So here, this is the routine one we use all the time. Sorry, go ahead.
Yeah, I would add, this becomes, in this particular case, the left main and the LAD were sized reasonable, but sometimes in a left main case, you get really sort of a rapid tapering of your vessel. And then we're used to sizing distally, but I think in this particular case, you do have to size, you have to be careful because if you need a large enough stent, of course, in the left main, you don't want to use, if your stent can't expand, you have to be a little careful. So sometimes better to use a larger stent, maybe deploy it at a low pressure inflation. So for example, with the Zions, you're stuck, your 3.0 is not going to allow you to go to a larger size as 4.45. So, if your LAD was too small, you may want to have to just kind of gently release a 3.5 so you can allow you to expand it in the proximal left main.
I think a question that comes to my mind here is maybe for you, Ahmed. Like how far back into the left main do you stent? Here we have like a Medina almost 0.11. Do you have to cover the whole left main? How much you cover? How you make that decisions?
So with based on imaging, if there is a good landing zone in the left main, I would land anywhere with allowing 8 millimeter or 6 millimeter, depends how small is the balloon in the catamaran. So I would assure that I have a balloon to pot with like if it's a 6 millimeter, then it's a 6 millimeter area that I would like to cover around maybe 1 millimeter to just for safety when you are throwing this balloon into the left main, so you don't touch the intima. And that's it. This is how much I cover in the left main, if the left main is fine.
Yeah.
The only thing I would like to comment is back, to be honest, Ashraf, and I really congratulate you on this, is it's DK crush or nano crush is a 60-step procedures. It's a hectic, but you have to do it step by step. Otherwise, it would take more time to revisit the branch rather than just making the efforts to recross and re-balloon before you put another layer of stents. It could be a misery to just try to rewire 2 struts and pass a balloon in it.
This is really a crucial point because really this is like a technique that you should not actually like make shortcuts when you do it, because if you do, you will end up being stuck and you will not be able to actually completely finish the procedure in a safe way and cover all the bifurcation as you would like to have like a very good long-term outcome. So going back to the pot, as you mentioned, the proximal optimization. So it's very crucial. So you always need to make sure you have enough stent in the left main where you can actually use a short balloon. Here we use a 4.5 times 8 non-compliant balloon. I think it's also important to point at, you really have to hit the carina because you are like kind of rebuilding that carina. So you need to make sure you hit the carina well. You do the proximal optimization then of the whole left main stent before you recross into the side branch. Because this is important, because if you make this shortcut and don't do this step, then a high chance that your wire that you will use to rewire the branch will go between the struts, behind the struts, abdominal. And then when you start ballooning into the side branch, you start like literally damaging the left main stent, crushing it, and making a bad situation worse. So.
I would add, stent boost is actually very helpful in this particular case to really know if your system has stent boost or similar, depending on obviously what equipment you're using, to really see where that carina is that you've created with the stents.
It's a cheap, available OCT all the time.
Yeah.
So.
Little extra radiation.
So the next step here, we are bringing a pilot 50 wire to rewire the branch before we also reopen the side struts, before we do the kissing. Maybe a question to my colleagues, Ahmed and Rani. Do you rely on angiography here when you rewire the branch, proximal versus distal strut? Do you do it live with imaging or by the feel? I find this is something that people do in a different way. So.
I changed, to be honest. I used to do it completely on the feel and how it's going and try to zoom in and go high in radiation, even 30 frames sometimes, going crazy in frames in fluoro just to know exactly where I'm going. Currently, no, I just go and use the other wire to OCT and know exactly where I'm crossing. It's much simpler and much less radiation, at least for me. The way that I was doing it, I think it adds a lot of radiation and then the procedure should, with your speed that you're going, should end up less than 1 gray, if the patient is, reasonably sized. So I would use OCT to recross at the end, at the final image or IVIS, whatever you.
And how do you use it live? Maybe if you describe to the audience in general, how you
So
use it.
you could do it either, you could do it live, or you could just do it with like retrograde. You just do the rewiring and you check your wire if it's actually you recross in a favorable area or not, just to decrease the amount of metal and the carina, the new carina that you created. I think it's much easier, to be honest. The old way is doable and people are doing it and been doing it for a while. I don't think there is a big problem in it, but I feel much better that this is a much better way. This is, you exactly know where you are crossing using the OCT in comparison. And I changed a couple of times. I crossed, and then I looked at the OCT. I'm not crossing where I'm thinking I crossed, and then I repeated my crossing.
Agarwal, I think you have a question.
Yes.
I think one of the practical things for recross, what we do in our cath lab is we ask the tech to double mag it, or the maximum magnification, whatever is available in your equipment. And he fixes only that area of the left main and its bifurcation. Like in this case, I would have done the double mag, gone into the LED with the wire like the Pilot 50. And then, so it's a double mag, it becomes very easy to put the wire near the carina into the left circumflex. And later on, you can confirm it. If you want to be very, very sure, you can confirm with your IVIS. It becomes a little bit more easy with the double mag.
I totally agree with this, but since it's a lift main case anyway, so I would use imaging of the creatinine is around me. So might as well just use the tool over and over since it's open.
So Ahmed, you mentioned the 16 steps. Is this an additional step? Is OCT? Is it?
Yes.
So 17 now. By
OCT will be done at least pre, maybe middle and post. So, to be honest, I still don't believe it's at any to the contrast of the procedure, because you're gonna need way more puffs if you don't use OCTs. That's what I.
Yeah, I mean, obviously it depends on the renal function, contrast use. I mean, IVIS maybe. I like the stent boost. I've been finding it. I mean, again, it is a little bit of the radiation, but coning in, zooming in, doing a stent boost, really, you can really see where your wire is. Taking the wire into the main branch and pulling back, and so you can really make sure you catch that distal cell is helpful also.
So the next step here, we are doing the kissing. When you read the literature of kissing techniques, the classic kissing, then DK crush and all of that, it is quite complicated. And as you mentioned, there are many steps. But what I like about this technique, when you have double rewire nano crush, you only do kissing once, because I think the first kiss in the DK crush is actually just to make sure you'll be able to rewire the branch. So in this case, when we do it in this more simplified manner, we have a very high success rate, recrossing into the side branch, and then do the procedure with single kiss rather than 2 times.
how many kisses you do? How many kisses?
So here one. So
No, at the end, to the end, how many kisses you?
like,
I mean, you start at least 2 kisses. I think
For
there are.
DK crush, you need 2 kisses.
Yeah.
When you cross and recross.
The third one
But
I've heard.
this one,
is
you can escape with one.
One.
with
Yeah,
one.
that's exactly what I meant. This technique, the nano crush, double rewire nano crush, you only need to kiss once.
So nano crash means how many millimeter?
Just
inside?
like less than a millimeter.
Can you make that? Sure. I mean, it's how.
So you
this
have
is-
to.
Nano,
Yeah,
I
and
heard.
also you have to do imaging to make sure at the end that it really covered. So
That's why imaging is important.
yeah.
Tony or Ashraf, what's your, how would you size the balloon, and what type of balloon you would use for the DK crush here, or sorry, nano crush here?
Yeah, I mean, I for me, NC balloons I have been used just to make sure that the stents, and I'll size it mostly to the distal vessel in this case. But I know that, some people do take a technique with one NC, one semi-compliant. So, see if those have different. In this particular case, we did use two NCs for kissing.
I think it's maybe 2NC would be difficult if you are using a 6 French, but otherwise if you are using 7 French, 2NCs would be great.
So here we did the kissing part, and as you can see, the balloons opened very well throughout, like the bifurcation into the proximal part of the LED and the proximal part of the circumflex coronary artery. So then the next step here is the repot. So if you go through the steps after the ballooning and so on, is like pot, kiss, pot. So this is now the repot, and we essentially choose a balloon that is size 1:1 to the left main to do this part of the procedure. I'll to you in a second. I think one of the limitations of this like two-stent technique in general is the number of like balloons and equipments you use during the procedure. So I'll show here in a minute a way to actually continue to reuse your same balloon during the procedure to reshape the balloon in a way so that it can easily be delivered into the lesion and even between the struts of the stent, rather than open a new balloon each time you need to balloon the stent. This is important, especially for two-stent techniques, especially when you are using a larger balloon like 4035, because when it deflates, it becomes very hard to actually to be re-advanced back into the lesion. So here's the technique. I'll just quickly describe it. So essentially, after this is the same balloon that we used at the beginning. So essentially, you put the stylet that came with the balloon from the box back into the balloon itself, with the plastic cover over the balloon itself, and then you go like up to 4 degrees on the inflator and down, 4 down, 4 down 3 times, and then literally when it comes out of the sheath again, it comes like as if it just came back out of the box, and very easy to deliver to wherever you want to deliver it to.
So Ashraf, if it's true trifurcation, but this is not a true trifurcation. If it's a true trifurcation, what would be your strategies will you use to guiding? What do you think?
Yeah, so essentially, the initial diagnostic pictures, when this case was referred to us, they didn't open the bifurcation. So it looked as if this high OM was coming from the left main. But when we did the proper pictures, it became obvious it's just like a high OM. We didn't need to do much about it. But when we had, I had another case, which we had to choose between which one, where it was like a true Medina 1111. So what we ended up doing is we used the drug-coated balloon to the ramus branch, and then did the nano-crush technique for the LED and the circumflex coronary artery.
Another question.
Yeah.
Yes.
If you have only osteal involved in the circ, and you want to stent from LAD to left main, would you use drug-eluting balloon for that osteal, avoiding 2-stent strategy rather than 1 stent with the drug-eluting balloon for the circ, only osteal involved?
I will ask my colleagues, what do you think?
So disease in the LAD and left main,
Yeah, so
but
you have
short osteals.
yeah.
lesion.
LCX is also disease. So if it's very short, will you use TCB in that one?
I think, well, it's always the risk, but I mean, in the end, if we can take a provisional approach, that's probably the better approach in reality. And if it's a short lesion, less than 10 millimeters in your side branch, then provisional approach is very reasonable. I think it's, we don't have good data in regards to that, but that would be something, again, as long as you have your bailout ready to convert to a 2-stent strategy, then it's not an unreasonable approach. I think.
There is a
balloon the side branch.
JAC publication about this available. So there's a data. Ahmed.
For me, to be honest, if it's something I cannot tap easily, I don't drug balloon it. I don't know that I'm for sure. And it's all as well based in imaging. If it's a calcified lesion, I think it will not, drug balloon will not do anything for it. I don't drug balloon it. And if it's something that I cannot recross very quickly and do a tap, and tap would be very easily deliverable to that, I just think it.
So I think we just did the photo. We are in the process of doing that, the report, which is the second one, and then we'll take the final pictures and the OCT images in a minute. But I think overall, there is conflicting evidence out there to which technique to use for left main bifurcation. There are studies that show DK crush is better than other bifurcation techniques, but there are also recent studies that showed that layered provisional, not the simple provisional where you're just stenting across, is as good as two stents technique. But I think it's very crucial to point at, it is really not just the simple provisional where you are just stenting across. No, you have to do like in a layered way, and you have to do the pot and kiss the branch. And if you be ready that if after kissing the side branch flow is low or severe lesion, that you can add a stent, then that is equivalent, but not just a simple provisional technique comparing with an advanced two-stent technique. So
Yeah, and I saw in another lecture was actually really nice. I mean, if you go in as a provisional and convert to a two-stent, it's not a failure. It's just the next step in the process, and it's just a better way to just think about it when we take a
Here's a
provisional approach.
question from the organizer. If you have you want to do triple kissing, would you use what will you do for triple kissing? Use 8 French, while I use ping pong technique? Which one you prefer? You do triple kissing through trifurcation.
I think they call it tissing. They call it, I think. No, I honestly rarely do it because if I have a third branch, I will use just drug-coated balloon for that and deal with the rest. But I don't know about.
Ahmed, we want answer from you.
I did it once, and it was pre-planned, to be honest, for a trifurcation, and it was 8 French, because I knew we might deliver 3 stents and we might deliver bigger tools, but that's only once. I only used 8 French in my life twice or 3. So that's not very common. Yeah.
So here we are approaching the end of the case where we just are giving nitro and we are set up to take the last pictures. So as you can
Yeah, 4 minutes, huh?
Yeah, so literally just like this is the whole case in live, really not much editing. So I mean, when you do it very often, you have the technique in your mind, you're going from one step to the other very quickly. It becomes like a very smooth, like half an hour, 45-minute procedure. So they are taking the pictures in a minute, but I just want to use the last few minutes of the presentation about OCT roll, and I'll show you the OCT images we did here in a minute. So OCT in this case is crucial. I think ideally actually should be used pre and post. Pre, you use it, you actually plan your like stenting based on that, based on the morphology, as I mentioned, the size you get and so on. So here you can see the bifurcation looks very well on the angiography, at least after we did the procedure, but then we ended up doing the OCT. The thing about OCT is on the post PCI images, you can also look at the things you need to look into, like dissection, apposition, expansion, and so on. You can look into them in really good details. And I think when you do the procedure in a very nice way and you image it, then you have a much better overall long-term prognosis compared with just like simple PCI, not guided by imaging. And I'll show a study in a minute. So
The question from Musa is asking, IVUS or OCT? Why? What determines?
I think many factors, but in this case, I think we chose OCT because of like higher resolution and the bifurcation and so on. But IVUS, I use it routinely for like ostial lesions, the CTOs, whenever there is dissection and so on. So I would prefer IVUS. So here is the OCT. You saw the co-registration part that we did. And then we literally assess our stent in details, like great, like expansion, well opposition, no evidence of any major complication post or pre or post the stent itself. A small dissection you saw there, and you can see the ostium of the circumflex coronary artery coming out of the vessel where that white dot is. You can see here on this view the 2 wires, the wire that's going down the LED and the other wire that's going down the circumflex coronary artery. The beauty of OCT is really high resolution. So here you can study it in details, as much details as you need, and literally go through the pictures one by one. I just want to use the next few, like 1 minute, if you don't mind, to present a study that was just published that presented at ACC a few days ago, which is really very relevant to this case, that compared complex PCI with imaging versus just complex PCI based on angiography, just published March 5th, 2023, in New England Journal of Medicine, Renovate Complex PCI. This is the kind of patients they included: true bifurcation lesion, mainly left main, chronic total occlusions, unprotected left main PCI, calcified vessels, multiple stents. So definitely our patient is kind of that kind of patient they included. very much significant reduction in target vessel failure when they use imaging compared with angiography. And I think more important to me is when you look at the table, there was actually reduction in cardiovascular mortality when you look at intravascular imaging compared with angiographic guided complex PCI. So I think really imaging is a must, whether IVUS or CT, but imaging is a must when it comes to complex bifurcation PCI. Thank you so much.